So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard.
What's good, fam? It's your host, Jimmy Pruitt, aka PharmD and the ED, and I'm bringing you the episode of the Pharm So Hard Podcast. Today, we have a special episode lined up, and I'm really, really excited that I'm not going to be doing most of the talking. I'm going to be leaving it to my buddy Hunter here to really just talk about something that is super cool. And I think some of you guys are doing it, but I bet most of you guys are not doing this. And we're going to go ahead and just really jump right into this. But before I get too far ahead of this, Hunter, again, introduce yourself. Kind of tell us your background and how you ended up in ID pharmacy and stewardship.
Certainly. So, hi everyone, I'm Hunter Rondeau. I am a antimicrobial stewardship coordinator at SSM Health in St. Louis, Missouri. I love ID, and I usually started off right with ID stands for it depends. Some people don't like the gray area. I freaking love it because that's what keeps every day interesting. No 2 days that I've had in my job have ever been the same. So, little background on my training. I kind of jumped all around the country. I did my PharmD at the University of Kansas, so Rock Chalk Jayhawks. But then, I wanted to go way across the country and did my PGY1 down at the University of Florida Health Shands in Gainesville, Florida. Thought, let's do the extreme opposite weather, and then did my PGY2 ID training at M Health Fairview, University of Minnesota. And then decided, you know what, let's stop with the extremes. Let's go back to the Midwest. And that's how I landed in St. Louis.
That's amazing, man. I feel I actually played football at Baker University, which is probably about 20 minutes south of Lawrence, Kansas. And that's to come up.
Oh, cool.
To come hang out, go to Brothers and all the good, cool places down there. And this was the time when KU won the men's basketball. So I was there, like 50,000 people. This is probably 2012, 2013, something crazy like that. So it was really exciting to kind of be in that environment. So we kind of get to connect on that. But let's go ahead and really jump into the nature of today. Today we're talking about single dose aminoglycosides. Again, you said your ED docs love this, your pharmacists again love it, or again, some people may be terrified. Either way, we want to kind of jump deep into this. So let us can you talk about what got you interested in this specifically? We kind of chatted offline a little bit before, but let the audience know, how did this become like your thing?
Sure. So I think one of the fun things about single dose aminoglycosides is I've yet to see this incorporated into the PharmD curriculum. So you learn about aminoglycosides probably from dosing them in the traditional versus extended interval. You learn about the HAP-VAP guidelines, how it's like your second option for someone with hospital-acquired pneumonia. But then you go into an ED and see these patients with super resistant gram-negative urinary tract infections. And then you hear someone go, oh, could we do a single dose aminoglycoside? And you're like, I haven't heard of this before. So it is so much like a cult following of people that love to do this. Where I discovered it, where I learned of this was when I was a PGY1 at UF. One of the PGY2 ID residents, Chris Balladad, was like, all right, if you're going to be an ID pharmacist, you're going to be looked at as the expert on every antibiotic. So you got to know the place in therapy of everything. And he was the one that kind of introduced me to the single dose aminoglycoside for urinary tract infections. So kind of after that, once I got to University of Minnesota, a lot of my staffing as a resident was in the ED. And I kept seeing this problem over and over again of where I'm sitting right by the ED physician. They look back and go, hey, this thing's really resistant. What are your suggestions? I'm like, let me see, because there's no oral options here. Certainly don't want to use oral ceftonir here, because I don't care if it says ceftriaxone susceptible. Ceftonir ain't going to work for this problem. And then that kind of opened the idea of, could we do a single dose aminoglycoside here? So, and then once that article from Goodlick and colleagues came out, that was like, all right, this is the evidence that I need to really start incorporating this into my practice. Although it's funny is while that review article is not that old, all the clinical data it cites, it's not new. So it's so much like, hey, you've been scared of this class of drugs for so long. Let's see if let's revive its purpose here.
the thing that makes it unique. Some of those studies that was looked at was older than me. Some of the things that's like, it's like super, super old, but then we look at some things as newer. But I think the realistic thing is like when you look at all of this, you say, hey, this makes sense from if you're going to treat any infection with like a single dose or something, the UTIs are the ones you want to hit. Especially we start getting into, and the terminology has changed as of late. But if we get into these patients that are not sick, like my doctors say, and they have cystitis for the most part, again, you have this scenario where you can really do something really good with them. One of the things I want to really piggyback off of is, again, you're saying your ED docs love this. Can you go a little deeper into like what this looks like at SSM Health as far as like when they're doing this? Again, can you get a little bit more detail? Because I think some people really want to know exactly the nitty-gritty of it, because people are doing culture callbacks. Again, we have folks in the ED that's doing this, but I really want to kind of drive home what this looks like for you so people can kind of say, I do something similar, I do something different, and I want to kind of dive into that a little bit.
Certainly. So I'll start with, it's primarily at my site. So I'm at SSM Health DePaul Hospital, that's where within the St. Louis area our SSM hospitals are doing an ED culture callback program. We want to expand this further, but we're kind of using DePaul as our pilot site first. And where we've really started to incorporate the single dose aminoglycoside is both the ED and in hospitalized patients, but the area that got people the most interested in it was definitely the ED. And I have to be very clear with this. It's not for every single patient. So that's probably the biggest thing, because we'll talk about this later, but there's a catch to using these. Like there's no one size fits all approach to treating patients with cystitis. But especially, and I think of probably the best example of this was a patient who had a very resistant E. coli, resistant to all of the oral options. They were part of our culture callback service where they got prescribed an oral antibiotic empirically. They continue to have symptoms of a cystitis. But the real interesting catch here was they had travel plans. Like they were flying the next day. And so the option, whatever was that resistant, they have this bad of cystitis. It's like, okay, is it bad enough to where we need to pull you into the hospital and do IV antibiotics? Do we try and throw a central line or PICC line in the community, which like people hear like, oh, just start IV antibiotics. Like putting in a PICC line in someone, especially in the community, is not an easy process. So then in this specific patient, it's like, what if we just have you come back to the ED, we give you a single dose of aminoglycoside, that treats your cystitis, and then you're on your merry way. That's where they did it, and that's kind of one of the stories that they love to use is, this is the place in therapy of this drug.
Absolutely, man. I think everyone's kind of has their patient. They have their moment, I would say. And when it happens, you're like, oh, okay. I remember I was at MUSC the first time I did this back down in Charleston, and I had a patient come in. It's like, hey, I am a healthcare professional. I know what's going on. I just need you guys to check the labs. I do not want to get poked. I don't want to do these different things. I just need you guys to check this. I've grown some nasty stuff in the past, and I need a different option. So they went back and forth. Before I got involved in the case, they went back and forth chatting about, okay, we can do this, we can do that. And then they wanted to do like single dose of like Rocephin and other things. Like, listen, guys, that's not going to buy you what you want.
Right.
I'll raise you. I'll raise you something that has a post duration of a couple of days. And I said, again, this is something that we can do. And I came back to the health professional like, this is why you have pharmacists in the ED. Because it's things like this. 90% of the stuff you can take care of a lot of these things you can take care of, but it's that 10% or that 25% of where you add just a different nuance and a different way to kind of customize the package. And I always tell people my job is to go from brain to vein. That's my thing. So I go from your head to the patient's vein in the most safe, convenient, and most efficient way. And that was one of those days where I was like, okay, I finally did it. I finally did something ID related that I feel very proud of. Because again, if you tell this other ID all the pharmacists like, oh, that's cool. Okay. I'm doing double coverage for MRSA bacteremia and, I'm just treating UTIs and unknown sepsis out of the ED. So we can kind of transition now into like this next component because I think people hear this and say, okay, that sounds cool. You guys are doing cool stuff. But again, I don't necessarily see the problem. They don't understand, why this may be something we need. And we kind of touched on it, but I really want to drive home this component of resistance and understanding that we don't have as many options. So again, what is the resistance landscape like at your institution? Are you seeing more ESBL in the community?
I would say it depends on your patient's history because, the textbook woman in her late 20s, it's her first urinary tract infection, it's probably not going to be an ESBL. But for patients who have had repeat exposures to antimicrobials, they've had a history of recurrent urinary tract infections, they've been exposed to a number of options. And when you use even a narrow spectrum beta-lactam, you're encouraging that E. coli to learn how to express a beta-lactamase. And it just keeps happening over and over and over, especially in our geriatric patients where, we have the big challenge of treating asymptomatic bacteria, and it keeps going and going until you get something so resistant to where the only options left are IV antimicrobials, where we get back to that same situation of, do you put in a central line? Do you get hospitalized for these antibiotics? So especially in my area, for those patients who have been exposed to so many antimicrobials, there's quite a bit more. I kind of look back to like where I trained at. The frequency of ESBLs, not as common. CREs, like those carbapenem-resistant Enterobacteriales, not near as common. Now where I'm at, I see the ESBLs daily, and I see CREs, I'd say weekly, monthly, depending on what the nursing home admission rate is.
Which is scary. Right. To me. Usually I see something crazy. I'm like, I'm going to call my ID buddies because, this is not something I want to see. But now I'm looking back like, actually, guys, we got to change the antibiotics again because you just can't do Benzos and close your eyes and pray anymore, because we got some nasty stuff here. So when we're talking about these ED patients that has these resistance UTIs and limited oral options, what was the typical approach before the aminoglycoside protocol?
Great question, because this is how I started to get a lot more involved in supporting our ED pharmacist with this. I hadn't even started in my role yet. They're like, the mid-levels were like, we don't feel knowledgeable on what we're doing with this resistance profile of a lot of these organisms. We're just throwing ceftonir because it says ceftriaxone susceptible. So that was the first thing I had to educate on. Then the second thing moves into okay, how do we build a collaborative practice agreement that captures a pharmacist be able to manage all of this stuff? And one of the first things I said was, look, all these times of just throwing ceftonir at these much more resistant gram-negatives and hoping it works, there's a place in therapy for aminoglycosides here, but there's also a huge important role of really making sure the diagnosis is right. So I think there was I need to go back and look at our data set and see about just what our frequency of prescribing for a lot of these quote unquote UTIs were, where I told our providers of like, look, it's okay to document asymptomatic bacteria. You can say, there's bacteria in the urine. I'm going to give it this diagnosis and that absolves me of having to throw antibiotics at it. But in order for us to have that CPA to work, I told them in order for us to be able to identify the right patients for the single dose aminoglycoside, we need a solid diagnosis. Unspecified UTI, I am not going to go, sure, Gentum. What happens if that was pylo? What happens if that was a more complicated UTI? Like there are situations where you can use a single dose aminoglycoside for those more complicated urinary tract infections, but the clinical data it's good, it's not as good. So it's one of those that, if it's just in the bladder, man, that gent's going to eradicate that. Yeah. But if there's residual stones, there's hardware, these other factors, I really had to ensure with our ED pharmacist and our ED docs of that's got to be documented. We need those details. If there's no symptoms, tell us there's no symptoms and we can tell you don't need gent. But if there are symptoms and it's all localized to the to the genitourinary tract, sweet, perfect patient for gent here.
Yeah. And that's one thing I always ask, like, hey, guys, what is this really? Because if I'm going back in a chart and trying to figure things out, looking at your physical exam, just try to capture something, which sometimes looks very similar from patient to patient, looking at that physical exam finding. But I really want to, I'm happy you kind of pointed out those patients that it's not for as well, because I think people get excited about things and we want to do the same thing for everyone. But I really want to kind of capture that part. Another thing, another aspect of this that I wanted to chat with you about was how many of those patients were actually getting things like ertapenem or actually an admission because no one thought about aminoglycosides.
Great question. We're going to have we proposed this as a resident project to get more of the baseline data, because when we started this process, we didn't have any baseline data to go off of. It didn't sound like there was a lot of community initiation of ertapenem, but there was certainly like a patient who was getting worse on the oral regimen, having them come back to get hospitalized because of something that was so scary. Because, the more R's you see on a report, the more scary you get, but you could have asymptomatic bacteria with carbapenem-resistant organisms, and you can still even gent those too. So I don't have a solid number for you on how many were coming back. I really want to get that data because that's going to show how impactful this culture callback stuff with single-dose aminoglycoside is.
Yeah, the biggest thing I was just thinking, like, man, am I seeing any of this? Because when I think about, we having the data will be great, but I'm thinking for me, I'm like, man, how many patients did I remember on shift getting admitted because they just didn't think of anything? And that for me is enough to kind of push this with administration, with my leadership, and with our ED docs and mid levels, because usually when I get involved in the case, it's usually when people say, okay, I give up. But there's a ton of cases where they don't, and they make a decision to go off of it. And sometimes those are great, sometimes those are not great. And I'm thinking there are a lot of patients getting admitted. And for me, if there's one or two patients a shift getting admitted for this, that's a fail from a systems perspective. So for me, one is too many per shift. And I would like to kind of focus. I wish I'm getting more FTEs. So I'm excited about being able to deeper dive into these patients when I have 100 patients sitting in my ER. But looking at this, I'm thinking one patient to me is too many if they fit the criteria. So again, if these patients have symptoms, they have it in the bladder, and they have some nastier bugs, but they're not sick enough to be admitted at baseline. Because usually my first question when I talk to my docs, I say, hey, how do you feel about this patient? Like, where would you send this patient if I can give you the perfect option? And they didn't need to be. Oh, I would definitely send them home. They're not sick. That's when I kind of get my clinical just thought and say, hey, you're not worried about this patient's symptoms right now as far as not being tachycardic, not having all these other components that make you worry. I want to see, before I get to the next step, again, I want to see how you feel before I can get this thing moved on. So we've been talking about really just like the problem of the resistance and just not having as many options and just the overall concept of aminoglycoside in clinical, single dose. We would be remiss if we didn't talk about some of the data. We don't have to spend a ton of time here, but I really wanted to kind of hit some of these big ones because I think people, they won't feel comfortable unless we talk about some of the data. So I really want to there's a few studies that was here that you sent over that people need to hear these cure rates, because I think that's going to really kind of put us over the board. So that first study, that systematic review, you kind of touched on earlier, that was done in 2019. Can you kind of just walk us through just a short brief of the numbers of those when you show people these, kind of what are their reactions?
Sure, yeah. And whenever I do the elevator pitch of this study, I try and keep it to, while the systematic review is new, the data is not new. There were over 13,000 patients included, both adult and peds. The cure rate, and specifically the microbiological cure rate, not so much a clinical cure rate, was well over 90%. The adverse event rate was less than 1%. And of all of the patients who had nephrotoxicity, we hit a whopping 0.05%. And nobody had any hearing loss.
Yeah.
So that's like the biggest thing. Like, people can criticize clinical cure versus microcure. I'll say like the most important one for me is clinical cure compared to microcure. Like there's actually quite a bit of data that says treating asymptomatic bacteria is bad because having good bacteria is good for having a normal urine microbiome. So we really try and focus more on the clinical cure data. But we'll talk about some of the other clinical trials that do have that clinical cure as a factor with it. But the key thing that I love about this study is the safety rate.
Mhm.
How many things in medicine have an adverse event profile where the risk of harm is less than 1%?
Yeah.
There's usually not much whenever they see this. In fact, we had a patient like just a couple weeks ago where, the team was worried. They had them on ceftriaxone. It was actually an inpatient setting where they were worried about, I don't want to miss this UTI. I'm like, this woman is 100 years old. All of her other vitals are fine. She's afebrile. She has no leukocytosis, but there's very clearly documented dysuria and symptoms of a urinary tract infection. And I put in a note that pretty much just summarized this study. It's like, look, I understand she's very old, but so is just as dangerous as it is to get aminoglycosides, so is it being in the hospital. The last place I want my grandma is in the hospital.
Yep.
If this aminoglycoside strategy was not utilized, they would have been in the hospital for another 3 days. And a lot of things can go wrong. What is it, like 10% of patients in the hospital develop an HI, or no, it's 10% develop like an HI or some type of like medication error, which is like, yeah, I want to get them out of there. And of course, they're a little nervous, like aminoglycosides to a 100-year-old. It's like she's peeing. She has nowhere in her chart anything that says CKD, nothing that says avoid nephrotoxins. And has a normal diet. She's talked with people.
Yeah.
Gave her the dose and on she went. Now, granted, it's kind of entertaining that the hospitalist was asking, can you just put in a note saying it's okay? I'm like, sure, I'll cite all the data here. I understand she's a little old, but she has nothing else that worries me.
Yeah. And that's the thing is like, we just get worried about a lot of stuff. And sometimes we need to be, especially when it comes to drugs, we need to be that person that helps everyone's worries. And I tell my PGY2 resident, Megan, I said, well, half of the job is treating the patient, the other half is treating the providers. And
Yep.
I say that in a way as of, I'm not trying to like belittle or kind of down talk, but my job is to make you be able to practice at the top of your license without having to worry. It's like having a team of lawyers. If you can do whatever you need to do, if you know someone's watching all these other things, and it helps maximize them. So I'm happy you would drop that note and really help them kind of progress forward. Now, the second one that we want to mention is something I think people would really like to hear with this our IDSA guidance with that. Can you kind of talk about that for a second? Because having that in writing helps a lot of people's worries.
For sure. And so there's criticism there's criticism on it being a guidance document and not guidelines. I'd argue it being the guidance document is fantastic because bacteria evolve faster than we can get published clinical guidelines, updated, peer-reviewed, and gone through the whole grade methodology. So if you look at the rationale for why this IDSA's gram-negative resistance guidance document in 3 different categories of ESBLs, AMP-Cs, and CRE, so that's the extended spectrum beta-lactamase enterobacterial or extended spectrum beta-lactamase enterobacteriales, your AMP-C organisms, which for those that can't remember, that's the one that if you give ceftriaxone at it, it can come back angrier and very, very angry. And then carbapenem-resistant enterobacteriales, which that one's terrifying because in the name, you can already hear like, oh, I don't think I can use many other beta-lactams there. All 3 of those, they list the single-dose aminoglycoside strategy as a alternative, which totally agree. It shouldn't be first for every patient, but it is still listed as an option, and with its endorsement, the reference is exactly that Good Lit article. They say, look, nothing changed. Like just because it's more resistant doesn't mean it's more virulent. Sometimes people see something with a bunch of R's all over it, but the patient's fine. Treat the patient, not the culture.
Absolutely, man. We go through all these things. It was okay. Now we have some guidance. We have these components, but then there may be still some doubt. I wanna study that was done, in the ED population. Because again, some people may be listening and say, "Hey, do you have anything for the ED?" And then you would say, "Actually, I do." Can we talk about this 2024 study that was done in academic emergency medicine?
Yes. So Jenner and colleagues article is my favorite. Whenever people go, "Oh, your big systematic review is old," I was like, it's small numbers, but it's still contemporary. It's that meme that shows it's not much, but it's honest work. Like, this is exactly what I have right alongside this.
Mm-hmm.
And especially it's prospective data. Like, it's one thing to have like a really small sample size of retrospective data. No, they follow these patients. And what's beautiful is this study very eloquently captures what does it look like to use this in practice.
Mm-hmm.
The patients who don't have source control, it's not going to work. Why? Because aminoglycosides aren't going to sterilize a stone. They're not going to sterilize hardware. But any bacteria trying to hold on for dear life in the bladder, you're going to get well over 8 to 10 times the MIC with a single dose of an aminoglycoside.
Yeah.
So that's why I stress this. Like, that article does so well of saying you're still going to have high cure rates, but based on those other things I said, yeah, this is where it's probably not going to work. Shocker, it didn't work for those patients.
Yeah, and I want you to kind of touch on, like, again, the percentage of resolved symptoms and the amount.
Certainly.
And then adverse effects. Again, we're pharmacists when we talk about that. So dive into that, 'cause I think that for me really helps.
Certainly, yeah. So when we look at the results of that paper, there were 13 patients. The complicating factors were male sex, kidney stone, urinary catheters, a recent urologic procedure, urinary hardware, and then allergies that prevented alternate oral options. Which, I mean, that happens quite a bit, where these patients they've been on a ton of oral antibiotics, so they're going to likely have some type of allergy because they've tried so much. As far as the outcomes, 10 patients, so 77% of the cohort, reported resolved urinary symptoms after treatment, and 11% of patients, or 11 patients, or 85% of patients, reported no new urinary symptoms since discharge. Nobody required a hospital admission for treatment failure, and no adverse events were noted. One of the things I really like with that one, too, is in the patients who did not have a good response, they talk about the follow-up. Like, did the patient's primary urologist say, "Oh no, this cystitis is so bad, you need to get hospitalized"? No, like, I remember when I was a PGY1 in the skills lab teaching at UF, one of the articles we did a journal club on was comparing fluoroquinolones to NSAIDs for the treatment of cystitis. Like, you're not going to die of cystitis. You can be wrong in the treatment of cystitis.
Yeah.
So that's what I really like here of, like, look, it didn't fix everybody. Key thing is follow-up. If you're going to do this and you're really worried about the treatment here, for especially someone who's got urinary hardware, stones and all that stuff, they need a urologist.
Yeah, absolutely. And that's why I always say, again, if you're focused on getting the patient out of the ED, what is the follow? So first, my ask, what's the dispo? Number two is usually, what's the follow-up? Do we have strong follow-up? And I think initially, when I first started doing this, I was like, hey, sorry if I'm asking questions you don't think I should ask. But now, again, being a clinical pharmacist, understanding the entire picture. So for me, understanding if this is a great patient, one, if we have the appropriate dispo for them, two, and then more importantly, and I'm starting to see it as I kind of mature to practice, understanding the follow-up is also something as well that I'm always wanting to figure out. And this study kind of highlights that. And I want people to realize these should be questions you're asking your team when you want to use this to appropriately be able to use this. And I think this data, if I have 85% of people who don't have these symptoms, that's a slam dunk for me. And if 0% of them have adverse effects, that's a double slam dunk for me. So I feel good about that one there. The fourth study we want to chat about, this is kind of a sicker population, I would say, or they had some, I shouldn't say sicker, we should say they had some nastier bugs to begin with. Can we talk about this fourth study that we have?
Yeah, so Hinata and colleagues, this is pretty much looking at a similar strategy of how do these aminoglycosides compare against or how do these aminoglycosides compare looking at these more resistant isolates? What's beautiful about this one is they talk about length of stay, which, as someone who works in a system role, getting patients out the door quickly and safely is very, very important, especially in the climate that we have right now. It's expensive. Healthcare is so expensive. And the last thing, if there's anything I can do with these single-dose aminoglycosides where I'm trying to find, is this the right time to use it? Can it avoid an admission? Like, you hear all the data about patients not being able to afford a living paycheck to paycheck. Imagine getting a surprise hospitalization for something like this that could have been avoided with a single dose of aminoglycoside. So what's beautiful with this one is this is a retrospective cohort study of 66 patients. In one group, 33 got aminoglycosides, and then the other group of 33 patients just got standard of care. The relapse at 14 days was pretty similar between the two, 3% in the aminoglycoside, 9% in the standard of care. The big difference is length of stay. Those that got the single dose aminoglycoside, length of stay was 4.5 days versus almost 2 weeks in the standard of care group. 2 weeks in the hospital is a very long time.
You're just begging for a secondary infection. You're
Exactly.
You're begging for a fall. You're begging for them to choke on a turkey sandwich. You're just begging for it.
Exactly. Again, the safety outcomes here are fantastic. There's no AKI, no ototoxicity, but a key thing here, and this is the one where I like to stress, like everything that sounds fantastic, there's some catch. And that's where almost a third of the follow-up culture showed some type of resistance to aminoglycosides. But I mean, that's one thing to drive home here is even when we use antibiotics appropriately, we give the bacteria a reason to fight for their life and to develop resistance. Now, how durable are those resistance mechanisms? Like, how long is it going to express that? Like we've seen, if you don't expose that bacteria to an antibiotic, it can say, you know what, it's not worth producing these resistance mechanisms again. And it goes back to like its native or like wild type. But there's not great data for that right now.
Yep.
And I haven't had enough patients where I've seen them get an aminoglycoside and then have time away from it to where I can see it go from resistant to not.
Yeah. And I think this is why I like being very evidence-based. And I joke a lot and I ask my providers, I say, what type of EBM are you practicing? Is this evidence-based medicine or emotion-based medicine? Like, which one are we practicing? I mean, we need to see the full picture. And again, that's why we say, hey, let's look at the total picture of this and figure out, because one thing is like, these are people who had nastier bugs to begin with. And they had these are things that you have to look at. Again, 66 patients, this retrospective. But again, it's something that makes you say, okay, if I do this, I can get the patient out of the hospital. I can potentially, and obviously, it's like I'm gonna save them about 10 days worth of being in the hospital compared to this study. But we have to always look at the full spectrum of this. So we talked about data. We talked about some of the reasons why we got this. As we kind of transition to a little bit more of the practical side of this, some people may be asking, okay, how do I do this? What's the dosing, et cetera? And we can just hit some of these and you can kind of just go through. I know I have a few different questions listed here, but realistically, you can kind of hit me with your protocol of, again, how you're giving these single dose aminoglycosides.
Certainly, yeah, that PICC Pearl, which for people who've never heard of PICC, it is like the Kentucky Antimicrobial Stewardship Consortium. They just have a bunch of these beautiful one-page stewardship pearls, and this is the one for the single dose aminoglycoside is fantastic because it summarizes that literature, it talks about the dosing strategies, and at the very bottom, it says, here are your antibiotics and how to dose them and when to do the adjustments. I would argue that adjusted versus ideal versus actual body weight, you're getting such high concentrations in the urinary tract. I usually tell everyone just do the actual body weight dosing, do adjusted if they're obese. If they're morbidly obese, like we had a patient the other day that we were considering this in with a BMI of 80, maybe that's the patient you do ideal body weight in. Because remember, the drug is like almost exclusively excreted in the urinary tract, so it's all going to go there. So dose adjusting for obesity, it's not beneficial. At that point, it's just, you could argue, is more harmful. And especially all this clinical data is not obese patients. These are all much more normal body weight patients. For dosing, so gentamicin 5 mg per kg as a single dose, tobramycin's the same 5 mg per kg per dose, and amikacin's 15 mg per kg.
Perfect. And I think some people also figure out what's the dosing, and because for some reason when people try to order Gent or some of these in my shop, the first one that pops up is going to be like what they use for like OB and like 130
Yep.
milligrams, or it'll be like 1 milligram. I don't know why this happens. We have to work at IT, but we're such a big system that it's almost impossible to get things through IT at times. But 5 mg per kg never pops up first for Gent. Do you have a particular one that you like, one versus the other? I say Gent because it just rolls off the tongue a little better for me. What about you?
So it depends on the situation. So because of the new breakpoint, or I shouldn't say new, it's been still a couple years now, but I actually have pretty defined ways of how I use these. So Gent is your go-to for most of your antibacterials. Tobramycin or amikacin you'll want to save for Pseudomonas because there are no more breakpoints for gentamicin and Pseudomonas. That was actually one of the first programmatic changes I made whenever I came to this health system was, this is going to confuse a lot of people. I want on every isolate with Pseudomonas to report Gent as resistant. I don't care what the result is. I want to help train people when they see a culture that says Pseudomonas, just report it as Gent resistant. So we haven't had any issues with people seeing Pseudomonas and going, oh, well, we can use Gent because it's not showing up there. So for Pseudomonas, that one we'll use tobramycin or amikacin for. For patients where you're going to use intramuscular dosing, this is one of those that just from experience you learn what works best. Amikacin has the least amount of volume for a 15 mg per kg dose, and so whenever you're trying to give intramuscular injections, if you do the math of like a 5 mg per kg dose of Gent in a 70 kilo individual, that's almost 9 mils. That's a lot. So we've got some strategies on how to manage doing an intramuscular injection of that, but amikacin, a 15 mg per kg dose in a 70 kilo patient, if I did my math right, was like 4 mils. So it's like half as much.
Yeah. And I was being cruel, giving double shots and different 2 thighs, 2 shots of Gent when I had the IM one. So one thing that people always, this is something that came up for me, is that when they try to order it, it came with the traditional pharmacy to dose and get levels. So
Yep.
people will say, oh, do I need to get levels for this? Like, what's kind of your guidance with that? Again, we use it, so we get it, but kind of what's your guidance when people say like, hey, how do I handle, we always have to get levels for this.
I'm so glad you asked that because I was ready for people to give pushback. Go, I got to do levels and all this stuff. I haven't gotten anybody to give me pushback. They're just like, oh, cool, that's it? Do I need to put... The biggest education point has been, do I need to put in a pharmacy to dose consult? I was like, no. In fact, it's actually going to be much easier for you to just put in a one-time dose of this, and that's going to communicate to everybody, you don't want pharmacy to manage this. You don't want pharmacy to get levels. You don't want pharmacy to do a progress note. So operationally, it's so much easier to go, hey, just if you think this is the right med for the patient, then pharmacy will verify it, but pharmacy doesn't need to follow and do levels and notes and all this stuff. Like, that's a total waste. The very first time we did this, because I had assumed people had done this before, learned very quickly, nope, got to do education. Of course, it's like a Friday afternoon. The provider put in a pharmacy to manage consult or pharmacy to manage aminoglycoside. They put in a 24-hour expiration on the order, thinking, oh, that's enough to communicate to them. The pharmacist puts in every 24 hours, gentamicin at 5 mg per kg, sets up levels and everything, and they text me freaking out like, I haven't done this before. What am I supposed to do? It's like, I should have done more education. That was my mistake because I dropped off and told them, like, oh yeah, just put in a one-time Gent order. And they put in a one-time pharmacy to manage order.
See, that's the thing, is like, these are the tidbits that we get when we kind of talk through these things, because yeah, it sounds great. And I think when you just look this up, okay, yeah, but they're like, operationally, oh, this is very, very different. And we have to make sure we do that. Another thing I want to kind of hit is like, who should not get this? And a few of these patients I've actually had over the last week, so it kind of makes me think through. But what patient population? Again, we're not necessarily, the different types of UTI, complicated with stuff. Take that aside. What other patients should not get single dose aminoglycosides?
Great question, because you don't come across a lot of these patients, but once you do, you're like, can I hear? And I'll say I've pushed the envelope on people with renal impairment, because as long as they are making urine,
Mhm.
the jet will get, or the aminoglycoside will be cleared. If they are not making urine, that aminoglycoside has nowhere to go, and all of the concerns of toxicity with ototoxicity and nephrotoxicity, that now becomes way more risky. So I usually phrase it as, if they are anuric or they have severe renal impairment, no, we're not doing this. This is not safe. We've done it in a dialysis patient before. The challenge with that is, like, okay, you can argue that they've got renal, or they have something to clear the aminoglycoside from, but I found also a lot of those hemodialysis patients, it's not actually a UTI. It turned out to just be, oh, they got a UA. They've got a bunch of reasons why the UA is going to be abnormal, that this didn't even need aminoglycoside to start with. But those severe renal impaired patients, where that aminoglycoside, a single dose is like giving them a week of an aminoglycoside, sure, it's going to clear, but that is not well studied at all. So I would argue, there have been situations where we do that, because that was like our only other option, but that is few and far between.
Mhm. Again, what about these patients that maybe, like, again, think about pregnancy, or like the myasthenia gravis patients? What's your thoughts when it comes to those? So again, we're trying to make sure we kind of pinpoint the right patient, and also give people the guidance of people that may not be the right patient.
Certainly. Myasthenia gravis, absolutely not. The neuromuscular risk with that, just nope. There are other, that is someone I'm not going to risk that with. And pregnancy especially too, even though they're at greater risk of urinary tract infections, no, they're an understudied population. And especially with them, I've yet to see as many pregnant patients have ESBL more resistant phenotypes with them. Although we have had patients that had a more resistant phenotype, and some of these newer pharmacotherapies that are available to treat cystitis, they are not safe in pregnancy. I think the only one is like pivmecillinum or Pivea. That one might have a niche in there, but I still haven't been able to get a hold of that medication.
That makes it great. So we kind of talked through, again, the nitty-gritty operationals. There's a lot of talk right now about ED culture callbacks, and we're phrasing this as a tool within there. You're in the process of doing all that. Can you tell us about the culture callback program? Again, how does that work? So people can kind of take some information from this to be able to apply to their own practice.
Certainly. And I should say, as far as the culture callback program development goes, I serve primarily as a consultant or advisor to help make it. The real work is done by our two fantastic ED pharmacists, Alex Metzger and Kelsey Johnson. They've done a fantastic job with it, and especially involving, like, there have been times where they're like, hey, is this a good one for the single dose aminoglycoside? So there was a lot of identifying, yep, that's a good one. Ooh, definitely not that one. It was those two that identified that patient of, okay, they have this flight. Do we admit them for IV? Do we try and get one of these other oral options? So having the ED pharmacist solid or very comfortable of, working with an ID pharmacist of, where's the right place in therapy for these? Because it's a little intimidating to start off trying to use these aminoglycosides. I like to call them, it's like a knife. Like, in the hands of a skilled surgeon or a skilled chef, you can create beautiful work. Like, you can create great work. But if you don't know what you're doing, it's like my toddler with a knife. Someone's going to get hurt.
Absolutely. Absolutely. And I think when I think through these different components, at my shop, one of the things that we're working on now is we're lucky in North Carolina, we have the clinical pharmacy practitioner, and where we kind of take that role of being able to not necessarily, we create this agreement, I would say we create the understanding of what we're going to do, and then we just go do it. So with ours, we'll have an epic inbox that we have all these, and we'll go through it daily, being able to kind of identify the patients that we need. We'll call on ones that we need to, and we'll have kind of a very strict criteria on what we need to kind of call them back for. The cool part for this, though, is that when we call them back to the ED, I would say that about half of those patients could get the single dose aminoglycosides. What I try to do is focus on prior to them leaving, because I wanna be aware before they get into that, and I try to use the culture callback as a follow-up for them. So I would like to see it to where, hey, I saw this patient, I remember them, I wrote something down about that, and then I'm gonna automatically get the culture back anyway. So, and I can call them to see how they're doing if needed. But that's kind of my way of having like a follow-up in a sense when it comes to the ED culture callback. And I did a lot of that when I was in USC, and this is something we kind of built into what we have, where I'm at right now at Carolina's Medical Center. And again, you've mentioned this before, but just kind of going through this kind of how it fits for me. But like you mentioned, again, this is reducing ED revisits. Again, the data, are you seeing that? Again, we don't necessarily need statistics, but have you seen that consistently from ED revisits or admissions since we started to introduce this a little bit more?
With the single dose aminoglycoside, yes. It's all anecdotal for now, so I can't wait for us to have much more data on this. But especially from those patients where there were much more resistant isolates, it's prevented readmissions. I've seen it prevent revisits to the ED because that's what they started with. I love your strategy of I'll just use the culture callback as like a prospective monitoring practice. We'll eventually get to that point. I'm actually leading my health system's urinary tract infection clinical pathway development. And one of the most important things I told the group was like, we've got to protocolize and give clear instruction on when to use this so then people feel comfortable with it, because aside from the IDSA's gram-negative resistance guidance document, there are no guidelines, there are no publications besides that say the single-dose aminoglycoside has a place in your ED. Yep. So institutional guidelines, though, providers can get behind okay, this says it's okay, cool, legally I'm covered there, because I understand they have good reason to think like, why would I give someone this aminoglycoside that is well documented in the literature to cause nephrotoxicity, ototoxicity, and all this harm? Why should I all of a sudden use this one study and start incorporating this when there's not a guideline to fall behind? Which you could push back and say, you have this one article, you can fall behind, but that's often the pushback I get from those that are like, I don't think I'm going to start doing this yet. I'll let my more adventurous fellow physicians do this first. And consistently I get the feedback from them of, if you can put this into a pathway or a guideline or something I can get behind, I'll do this. Like, I'll do this a lot more. Yeah. It's like, that's my job. So sure.
It is fair. It is fair. Now one thing, especially there are some times where I get to a new place or I go around, and some of my ID pharmacists may not have kind of been comfortable with this. I want to kind of switch gears here to like the stewardship angle and like the controversies behind that. So one of the things I see often is like the concept of people want to give ertapenem for outpatient and do like these, give PICC, do all these very complicated things. And for me, I think the aminoglycosides help from this. So from a stewardship lens, how do you rank like single dose aminoglycosides versus like ertapenem for outpatient UTI? If you can kind of just like weigh the advantages and disadvantages.
Certainly. I definitely give a strong preference to aminoglycosides because when we talk about stewardship, because oftentimes people hear stewardship and go, that's being the carbapenem police. My approach is very much, it's about the right drug for the right patient at the right time, right dose. What is it very clear a single dose aminoglycoside is great at doing? Someone's got a really resistant urinary tract infection and you're out of options, and this could prevent a hospitalization or prevent a PICC line. That is where I go, yep, there very clearly a benefit of using this here. Now, granted, I don't know how much longer that benefit's going to exist with so many of these newer oral options coming to market, but they're new. They're going to be cost prohibitive for many, and especially for where I practice, North County, St. Louis, most of my patients have no insurance or they have Medicaid. They're going to see these drugs and go, they're probably going to make me put in a prior auth and say, have you tried Ceftonir? No. So I think as those other drug or those other oral options become more available, maybe I'll lean or pull back from some of the single dose aminoglycoside because those other options are going to be way more well studied in an RCT format. But they're cost prohibitive.
Absolutely. Thousands and thousands of dollars for a course. So I think people need to kind of realize that. And then the next step is like the fear factor. And we've touched on it. But like, what's been like the biggest myth you've had to bust when like you're converting people over to this?
Oh, it's by far the nephrotoxicity. They think I'm crazy of like, because the ones that I've worked with longer, they're like, oh, if the ID pharmacist is recommending an aminoglycoside, it's probably okay. But the people who I've not worked as closely with, and I jump in and say, hey, can I help with the situation? They're like, what year is this? Why are we recommending aminoglycosides? It's like, hold on, let's talk about the nephrotoxicity. But it gives a good opportunity to talk about what we were taught and what we know on how to dose optimize, because I go, all right, what's associated with nephrotoxicity and aminoglycosides? They're like the troughs. I'm like, what happens if you give a dose and don't give another? Number only go down. In caveman speak, number can only go down.
You just can't get that hot over that period of time. And you mentioned this before. I don't necessarily want to dive too deep into it, but you mentioned that gentamicin breakpoints were removed for Pseudomonas systemic infections. For the average pharmacist, tell me how this actually affected your antibiogram interpretation and aminoglycoside selection, because again, we may not be aware of that type of stuff yet or how it impacts us. So we're talking about it again. Just simplify that for us really quickly.
Certainly. So we're actually looking at how it's going to impact our antibiograms this year. I just got the email last week about here's our new antibiograms. I'm like, oh, this will be the last year that we report aminoglycosides for certain categories. So the main one, which I kind of asked earlier on, of we got to get people retrained and aware of gentamicin has no breakpoints for Pseudomonas. So on the antibiogram, there should be a black box over gentamicin and Pseudomonas. You could still do it for tobramycin and amikacin if they are routinely tested. So for our health system, we routinely test only amikacin for our Pseudomonas isolates. Tobramycin is on our amikacin. Tobramycin's on our extended panel, so because we don't test for it every time, you can't put things that you only test in certain circumstances on an antibiogram. So what's going to happen is, because of those changes with the breakpoints and the different susceptibility cards that we have, eventually in our health system, the only thing an antibiogram is going to tell us is what the susceptibility rates of amikacin and Pseudomonas were. So it's going to maintain gent being the workhorse for many things, but it's going to very much put amikacin in for our Pseudomonas. Now, that doesn't mean you can't call the lab and go, hey, can you run the other card and let me get a tobramycin susceptibility result for the Pseudomonas? Like, you can still do that. It's just the antibiogram will have to do a lot of education on. That's why it's not there. That goes against how we make antibiograms.
That's perfect. I think a lot of times, again, I don't know about all ED pharmacists, but again, we'll see some of those things, but we won't get into like the nitty gritty like you guys are, especially just understanding, okay, well, now I have to kind of pivot when I have Pseudomonas compared to it being E. coli. So I guess to kind of wrap up this segment until we kind of go through some rapid fire here, just for everyone to hear it, is a single dose aminoglycoside a tool really sitting in a toolbox that no one's picking up? And what will it take to get more EDs adopting this for right now?
So I wouldn't say it's sitting in many people, it's sitting on a shelf. I think there are enough people that are like, I've used it once, had that patient story, and now they want to use it more. Now, to get more people using it more, I think it's going to require kind of what we talked about earlier, some EHR optimization, because it would be my dream to have like a pharmacy to manage UTI consult, and then they can just manage all that stuff. But I understand that's not feasible everywhere. So even just when the provider types in UTI, let there be an order that says, here's gentamicin 5 mg per kg. Here's tobramycin 5 mg per kg. Make it super easy. Like, if there's anything I've learned in all the EHR optimization work that I've done, is number of clicks is like the most important metric for providers. Don't make an order set that takes 12 clicks to get to something. It should be like 3 clicks and they will use it.
have everything ready to go. All you want is going to be there. So, yeah, I definitely agree with you, man. And so to wrap it up, I want to kind of hit some of these quick things that just make me think through. And I'll jump around here, but what's kind of been like the biggest mistake you see when it comes to this overall single dose aminoglycoside or this UTI treatment?
I think the biggest mistake is people, they do it their first time and they're like, oh, this is awesome. And then they think you should be doing it for everybody. It's not appropriate for every single patient. And I think that Kasich Pearl pretty eloquently summarizes these are the factors that make it more appropriate to consider this situation. It's like the new CAP guidelines. They're like, 3 days of pneumonia treatment is appropriate. That doesn't mean every single patient should only be getting 3 days. I have seen Mima dying on day 3, and the dumbest thing you can do is go, can we stop the ceftriaxone? Like, no, no. Requires individualization. Just like for 3-day CAP, so exists that recommendation for individualizing for single-dose aminoglycosides for cystitis.
Perfect. I'm going to hit the last two here. Again, your ED pharmacists are doing this, but what's one thing you wish every ED pharmacist knew about aminoglycosides?
Oh, think of where things are stocked. Like, think the ops. If you want to give it intramuscular and you really want to boast like great throughput, stock it in your Pyxis. Stock it in your Omnicell. If you want to be like, oh, cool, someone's here with cystitis and we've identified this is an appropriate patient to do amikacin for, have the vials in the Pyxis. That was something I totally blew past me. That was like, because I had asked, I was like, how long is it taking like to do all this? Like in theory, it seems like it should be super fast. They're like, oh, we have to wait for pharmacy to tube it. And it's like, wait, why don't we just stock it there? And that credit goes to the ED pharmacist. That goes to Alex because he was like, any reason why we shouldn't stock it here? I'm like, no, that's actually a brilliant idea.
And then lastly, I want to say again, this is just more of a general, like what's on the horizon for like aminoglycoside research? I think we've kind of went away from it in a sense in deference to these newer agents, but is there anything you're seeing or you would like to see?
So I looked at clinicaltrials.gov to see, are there any ongoing trials? And there are 2. I was surprised. There are 2 trials that really caught my eye. There's one, it's called the Choice UTI study, single dose intravenous antibiotics for complicated urinary tract infections in children. And then the second one was single dose amikacin for uncomplicated cystitis in the ED, a feasibility study. So people are still interested in this. And I swear every ID or even just pharmacy conference I go to, there's a poster or 2 about people doing this. It's just not as many publications about the topic. So I'd love to see more people. Like, you don't need that many patients to publish on this. I mean, look, one of my favorite articles had 13 patients? And that is practice changing.
Yeah, absolutely. So if you have any research that's been going, again, you can publish it in a journal of acute care pharmacotherapy if you like. We would like that. And then we just really thank you, Hunter, for coming on. So where can people find that pearl you mentioned earlier? The Kasich Pearl, where can they find that? We just Google it, or where is it like located?
Yep, I would just Google Kasich, K-A-S-I-C. And that's look for the Kasich Clinical Pearls. If you type, I'll test it right now. Kasich Clinical Pearl. Yep, first item that comes up, probably because I've opened it so many times. But usually what I'll do is if I'm like, oh, there's a good Kasich Pearl in this, because after you use it so many times, you'll remember which ones exist for which topics. I'll just type in Kasich Clinical Pearl, this topic, and it'll float to the top of Google.
Perfect. And where can people connect with you? Is LinkedIn or something? Is that the best way for people to get in contact with you?
Yep, I'd say LinkedIn's best. I used to be more active on Twitter and Blue Sky, but it's...
Yeah.
But LinkedIn, I feel like it's getting better with the humble brag. I think enough people are making fun of humble brag post. It's getting a little bit better.
That's been great. But man, Hunter, thank you for coming on. Thank you for making this, a reality. We fought back and forth to get the best timings with the Empower X conference coming up. But I'm probably going to try to release this right before it or the day of. So if you guys are hearing this, we recorded this a little bit before the conference, but we're super excited for that. Again, Hunter, thanks for coming on. Any closing words for the audience, pharmacists, physicians, everyone who's listening to the show?
Less than 1% nephrotoxicity. They're not that scary.
Perfect. So I'm hoping that we have at least one use of this over the next month for everyone who's listening, if you find the right patient population. So thank you for coming on again. I thank everyone here for listening to the podcast. I went through and I like, crap, we started this in 2019 and 100 plus episodes, and we're just super excited. So I thank everyone who's been listening from the very beginning, and I'm just excited because again, Pharm So Hard started out as what it was, and then we did a few things like going on the tour back in 2021, and then that led to the creation of the EmpowerRx conference, which then led to the Society of Emergency Medicine Pharmacists. So as these things kind of built on top of each other, it's been because of the community that we've built in emergency medicine and taking on new heights and new roles. I'm super excited for the future of what we're doing in pharmacy, and just the transition that we're going to take from being just DI people to really being the individuals who are helping side by side with our team. So I'm just excited where we're going. Excited to continue to do more episodes. It's been my mission for this year to continuously push a lot of things out, because I take a back seat last year because creating an organization and creating a PGY2 program was probably not the best thing to do at one time. So I thank everyone. Anna, thank you again for coming on. And guys, I close it out the same way I've been closing it out since 2019. You guys be a pharmacist, you guys work at ED, but everything you do, make sure you Pharm So Hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.